The clock is ticking. You can hear the fan whirring overhead in the examination hall. Your palms are sweating just a little bit. You flip over the paper for the Gujarat University MD Anesthesiology exam. And there it is. Question number 1, 20 marks. Discuss the pathophysiology and management of status epilepticus. Or, maybe worse, you're in the Viva Voce. The external examiner looks over his glasses and says, "Doctor, I have a known epileptic patient for a laparoscopic cholecystectomy. How do you proceed?"
That is the moment, isn't it? That's where you either shine or you crumble. And honestly, for the MD candidate, this isn't just about knowing the dose of Lorazepam.
No.
Anyone can look up a dose. The examiners in Gujarat, and really anywhere at this level, they're looking for structure. They want to see that you think like a consultant anesthesiologist, not just, an intern following a flowchart.
Exactly. And that is why we are doing this deep dive today. We aren't just reading a textbook. We are simulating the ultimate prep session for that exam. I've got my stack of notes here. Miller, Harrison's, the ICU protocols, and of course the Bible of Pharmacology, Katie Tripathi.
The essentials.
I'm playing the role of the stressed postgraduate student, and you are the senior MD faculty walking me through how to construct the perfect answer.
Okay. Consider me the senior faculty. Our mission is simple. We are going to build a comprehensive, bulletproof answer that gets you, let's aim high, 18 out of 20 marks.
I'll take it.
We need to cover the definitions, the why behind the physiology, the detailed drug protocols, and of course, all the anesthetic implications. A complete package.
So let's imagine I'm writing this answer. I can't just start with give oxygen. I need an introduction. I need to frame the problem. I was looking at Katie Tripathi last night, and the distinction between epilepsy and seizure is actually quite specific. I used to use them interchangeably, but that's technically wrong, isn't it?
It is, and it's a very common mistake. If you mix them up in the first paragraph of your answer, you've already annoyed the examiner. You have to be precise from line 1.
Okay.
A seizure is the event. It is the symptom. The definition you want to write down, and this comes straight from Miller and Tripathi, is that a seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain.
Okay. Abnormal excessive synchronous activity. So it's the electrical storm itself.
Right. It's the lightning strike. Epilepsy is the disease. It's the chronic condition. It's the tendency to have those storms. It's defined as a disorder of the CNS characterized by a chronic predisposition to generate these seizures.
So epilepsy is the stormy weather system.
Perfect analogy. And if you want to really impress, use the phrase from Katie Tripathi that I love seeing in exam papers, paroxysmal cerebral dysrhythmia.
Paroxysmal cerebral dysrhythmia.
That sounds expensive. I'm writing that down. It sounds scholarly. It tells the examiner you've read the book and you understand the rhythmicity of the problem. But after the definition, you need to immediately answer the so what? Why is an anesthesiologist writing 20 marks on this? Why isn't this just a neurology question?
Right, the relevance. Well, I see 3 main reasons. First, we are the airway experts. When status epilepticus hits the ICU or the ER, they call us to secure the tube and manage the deep sedation.
Number 1, absolutely.
Second, we have patients coming for surgery who happen to be epileptic, and we need to know about their meds, their interactions, all of that.
The perioperative management, critical.
And third, well, we call seizures sometimes.
We do, and that's the one we don't like to talk about. Toxicity from local anesthetics, withdrawal from alcohol or benzos in the perioperative period, or even, metabolic messes we create.
So my introduction should highlight those 3 buckets of relevance: ICU management, perioperative care, and iatrogenic causes. That sets the stage perfectly.
That's your opening paragraph. Done. You've defined the terms and established relevance. Now you can move on.
Okay, introduction done. Now, the examiner wants to see if I can classify the beast. I feel like there are a dozen ways to classify seizures, but for the exam, we need the high-yield version. I'm seeing a split between generalized and focal. Is that still the way to go?
Stick to that. It's the International League Against Epilepsy, the ILAE standard, and it's what's in the standard texts, like Guyton and Tripathi. It's safe ground. You have 2 main camps.
Okay.
Camp 1, generalized seizures. And the key here is that they involve the whole brain right from the start. Both hemispheres are firing simultaneously.
And this is where we get the classic grand mal, the one everyone pictured.
Exactly. The generalized tonic-clonic seizure, or GTCS, you lose consciousness immediately. You have the tonic phase, the body goes rigid, they start breathing. You see cyanosis, followed by the clonic phase, which is the rhythmic jerking. And then crucially, the postictal confusion and drowsiness.
Generalized also includes the quieter ones, right? Like absence seizures. I remember this from pediatrics.
Yes, petit mal. Much more common in kids. They just stare into space. There are no convulsions, just a momentary freeze. They might stop talking mid-sentence.
And then just pick up where they left off.
Exactly. And in the exam, if you want extra points, mention the classic EEG pattern. 3 cycles per second, spike and wave. The examiner will nod. He'll know you know your stuff.
Got it. 3 cycles per second. And then Camp 2 is focal seizures, or what we used to call partial seizures.
Right. And the name tells you everything. These start in one specific spot of focus. And the classification depends on what happens to their consciousness.
So if you're awake for it.
It's a simple partial. Consciousness is preserved. Maybe just your thumb is twitching, or you smell burnt rubber, or you get a sudden feeling of déjà vu. The symptoms depend entirely on where in the brain that focus is.
Okay, but if you zone out.
Then it's a complex partial. Consciousness is impaired. This often originates in the temporal lobe. You might see what we call automatisms, lip smacking, picking at clothes, fumbling with buttons. They look awake, but they're not there.
And the danger with focal seizures is that they can spread, right? They don't always stay in one place.
That's the Jacksonian march. A focal seizure can spread across the cortex and become a secondarily generalized seizure. It starts with a twitch in the finger, then the hand, then the arm, and then boom, full tonic-clonic seizure.
Okay, that makes sense. Now here is a critical clinical pearl for the Viva. The examiner loves this kind of practical question. He asks, you are in the pre-op clinic. A patient collapses.
Yeah.
How do you know it's a seizure and not just a faint, a simple syncope?
A brilliant question, because they can look similar for a few seconds.
Oh, that's a classic. Harrison's actually has a table on this. I remember one key difference is the color of the patient.
Spot on. Think about the pathophysiology. In syncope, or fainting, it's about hypoperfusion to the brain, not enough blood flow. So the patient goes pale, white as a sheet.
Okay.
In a true grand mal seizure, because of the tonic contraction of the respiratory muscles, they can't breathe. So they go cyanotic, they turn blue. Pale versus blue is a huge differentiator.
What about recovery?
Syncope. They wake up fast, maybe a bit woozy, but they are usually oriented within a minute. Seizure. They're postictal confused, drowsy, maybe for an hour. They won't know where they are.
And the tongue. I remember something about the tongue.
The tongue is almost pathognomonic. If they bite the side of the tongue, it's almost always epilepsy. The clonic jaw movements are lateral. If they bite the tip of the tongue, it could just be from the fall. So side of the tongue equals seizure.
That is gold. I'm storing that for the Viva. Okay, we've classified it. Now we move to the absolute meat of the answer. Section 3. Status epilepticus. The definitions here seem to be shifting sand. I was taught the 30-minute rule back in my MBBS days. Is that obsolete now?
It's not obsolete in a historical sense, but it's dangerous if you use it clinically. You'll sound out of date. You need to present 2 concepts to the examiner to show you are well-read and safe.
2 concepts. Okay.
First, the traditional definition. A seizure lasting more than 30 minutes, or a series of repeated seizures without full recovery of consciousness between them. You state that for completeness.
But you don't act on it.
You do not. Because if I wait 30 minutes to treat, the patient is going to have permanent brain damage.
Right.
And that is why we now use the operational definition, which you'll find in Miller and all the modern ICU protocols. This is the concept of time point 1, T1, and time point 2, T2.
T1 and T2.
T1 is 5 minutes. If a generalized tonic-clonic seizure lasts for 5 minutes, the natural mechanisms that usually stop a seizure have failed. It is statistically very unlikely to stop on its own, so you must start aggressive treatment. You treat it as status epilepticus now.
So 5 minutes is the go signal, the alarm bell.
It is. T2 is 30 minutes. That is the point after which we see evidence of irreversible neuronal injury beginning. The cell death starts. So the whole goal of the anesthesiologist, of the emergency physician, is to treat at T1 so the patient never reaches T2.
So it's time is brain, just like time is muscle in a heart attack.
That is the exact phrase you should use in your answer. Time is brain. It shows you understand the urgency. Treat at 5 to save the brain at 30.
Perfect. That's a great way to frame it. Then we have the other definitions. Refractory status. What's the time cutoff for that?
Refractory status is when the seizure continues despite first-line therapy, which is a benzodiazepine, and second-line therapy, which is a proper anti-epileptic drug. We're usually looking at about 60 minutes plus. The first 2 waves of drugs have failed.
It's super-refractory. That just sounds awful.
It is. That's the nightmare scenario. Seizures persisting for 24 hours or more despite continuous infusions of anesthetic agents, or seizures that recur the moment you try to wean the propofol. This is deep in the ICU, a real crisis.
Okay, so we know when to treat. But to really ace this 20 marker, I need to explain why the brain is dying. What's the mechanism? Section 4, Pathophysiology. I feel like most students just write excitotoxicity and move on. How do I go deeper?
You need to explain the mechanism, and you can explain it like a balance scale. On one side, you have GABA, the main inhibitory neurotransmitter. It's the brain's Burke pedal. On the other side, you have glutamate, the main excitatory one, the accelerator.
Brakes and accelerator. Simple.
In status epilepticus, the GABA system fails, the brakes are gone, and you have a massive, unregulated flood of glutamate in the synaptic cleft. The accelerator is stuck to the floor.
And that glutamate activates the NMDA receptors. That's what I remember from pharmacology.
Correct. The NMDA receptor is basically a gate, a channel for calcium. When glutamate pounds on it, the gate flies open, and you get a massive toxic influx of calcium into the neuron.
And calcium is the problem.
Calcium is great for bones, but inside a neuron in those concentrations, it's a killer. It activates proteases that chew up the cell from the inside. It poisons the mitochondria so the cell loses its energy supply, and it triggers apoptosis-programmed cell suicide and necrosis. That is the essence of excitotoxicity.
But there is another mechanism that explains why the drugs stop working, right? Something about the receptors moving around. I read about this in the OHS manual.
Now you're talking like a consultant. This is the aha moment for the examiner. It's called receptor trafficking.
Receptor trafficking.
Imagine the surface of the neuron. During a prolonged seizure, the GABA-A receptors, the very receptors that our benzodiazepines bind to, they actually internalize. They are pulled from the surface and sink inside the cell membrane.
So they literally go into hiding.
They hide from the drug. So you can push all the Lorazepam you want after 20 or 30 minutes, but if the receptors aren't on the surface to be activated, the drug won't work effectively. This happens within minutes.
Wow.
At the very same time, the excitatory NMDA receptors do the opposite. They move to the surface, making the neuron even more sensitive to that flood of glutamate.
So the longer you wait,
the fewer GABA receptors you have to help you, and the more NMDA receptors you have fighting against you. This is why early treatment is everything. It explains at a molecular level why late status is so hard to treat and often requires drugs that block NMDA, like ketamine, or just shutting the whole system down with general anesthesia.
That is fascinating. It's not just about ongoing damage. It's about escalating drug resistance built into the pathophysiology. And of course, while the brain is frying, the rest of the body is falling apart. The systemic complications.
It's a total system meltdown, a polysystemic catastrophe. You have to list these.
That's first.
Respiratory. You have apnea during the tonic phase and poor airway protection throughout. This leads to hypoxia and hypercarbia, which worsens cerebral edema.
Okay.
Metabolic. The muscles are contracting violently nonstop. This produces massive amounts of lactic acid. You get a severe metabolic acidosis. The pH can drop to 7.0 or even lower.
And that muscle breakdown must have other effects.
It does. Renal. This is huge. The muscle breakdown, rhabdomyolysis, releases myoglobin. Myoglobin is toxic to the renal tubules. It blocks them up. Acute kidney injury is a major cause of death in the days following status.
Rhabdo leads to AKI. Got it.
And finally, hyperkalemia. All that broken down muscle releases potassium into the bloodstream. This is what can cause fatal cardiac arrhythmias. It's a vicious cycle.
It really is. Okay, let's stop the cycle. We have to intervene. Section 5. Initial assessment and stabilization. The patient rolls into the ER. They are actively seizing, ABCs. But for seizures, A isn't straightforward, is it?
No, it's not. Airway. The jaw is often clenched shut in trismus. The first rule is do not force an airway in. You will break teeth, cause bleeding, and you might break your own fingers.
How's what you do?
You place them in the left lateral position, the recovery position. This helps the secretions drain out and prevents the tongue from falling back. You suction what you can from the side of the mouth. If you can slip a soft nasal airway in without a fight, great, but don't force anything.
Okay, B for breathing.
High flow oxygen, 100%, a non-rebreather mask. Their brain and muscles are consuming oxygen at a massive rate, and they are not ventilating well. You have to flood them with oxygen.
C for circulation.
2 large bore IVs. Don't waste time fiddling with a tiny 22-gauge cannula in a thrashing patient. You need reliable access for drugs and fluids. Get a 16 or 18-gauge in. D for dextrose. This is a mandatory step in your exam answer. A bedside glucose check is one of the very first things you do. Hypoglycemia is the most common and most easily reversible cause of seizures.
So if the glucometer says low,
you give 50 milliliters of 50% dextrose, or the appropriate pediatric dose, and you might just cure the patient instantly. The seizure stops. You look like a hero. Always check the sugar.
Okay, glucose is normal. The patient is still seizing. It's been 5 minutes. We are at T1. We are officially in status epilepticus. Section 6, the acute management protocol. This is the core of the exam answer. The examiner wants a stepwise recipe.
And you must write it in stages. Do not mix them up.
Stage 1.
Stage 1, first-line therapy, 0-10 minutes. The goal here is to rapidly potentiate GABA before those receptors start hiding. The drug of choice is a benzodiazepine.
Okay, which one? There's always this debate in the department, Lorazepam versus diazepam. What's the exam-safe answer?
For the exam and for modern practice, Lorazepam is the winner. The dose is 0.1 millikilogram IV, which is usually a 4 milligram vial for an adult.
And why is it better than diazepam? I need to justify my choice.
You do. Here is the pharmacological nuance for your answer. Diazepam is extremely lipid-soluble. It crosses the blood-brain barrier in seconds, which sounds great. But because it loves fat so much, it rapidly redistributes out of the brain and into the body's peripheral fat tissues.
So it leaves the target organ.
Exactly. Its duration of clinical effect is very short, maybe only 15-20 minutes. The patient wakes up and starts seizing again. Lorazepam is less lipid-soluble. It takes a minute or so longer to work, but once it binds to the GABA receptors in the CNS, it stays there. It has a much longer duration of anticonvulsant action, up to 12-24 hours.
So diazepam's a sprint, lorazepam is a middle-distance runner. We want the runner.
We want the runner.
But what if I can't get an IV? The patient is thrashing, the veins are collapsed.
Great question. This is a common real-world problem. Then you go intramuscular IM, Midazolam. The dose is 10 milligrams for an adult, or 0.2 milligram kilograms. Midazolam has excellent rapid absorption from muscle. Diazepam IM, on the other hand, is erratic and extremely painful. You don't use it.
Okay, benzo is in. We wait a minute or two, the seizure might stop or might not. But regardless of the outcome, we need to prevent the next one, right? We can't just rely on the benzo.
Correct. That's a very sophisticated point. Even if the patient stops seizing and wakes up, you must immediately move to stage 2. Second-line therapy. This is the stabilization phase. We are now at the 10-20 minute mark. You need to load them with a proper, long-acting anti-epileptic drug, an AED.
The classic is phenytoin.
Yes, phenytoin. The loading dose is 15-20 millikilogram IV, but you have to write about its dangers. Phenytoin is an ugly drug to give. It's highly alkaline, dissolved in propylene glycol. It causes severe phlebitis. If it extravasates, leaks out of the vein, it can cause purple glove syndrome, which is tissue necrosis of the hand.
And it's bad for the heart.
Very. That propylene glycol is cardiotoxic. If you push phenytoin too fast, you will cause profound hypotension and cardiac arrhythmias. You absolutely cannot exceed an infusion rate of 50 milligram N. It takes 20 minutes to give a full dose.
That's a key point. It's not a rescue drug, which is why we have its rich cousin, fosphenytoin.
Exactly. Fosphenytoin is a water-soluble prodrug that gets converted to phenytoin in the body. No propylene glycol. You can push it 3 times faster, up to 150 milligrams of phenytoin equivalents per minute. Much less hypotension, no purple glove. If your hospital has it and can afford it, it is superior.
What about Levetiracetam, Keppra? I feel like everyone in our ICU uses Keppra now because it's so easy and safe.
And the guidelines are catching up to that practice. The dose is 1,000 to 3,000 milligram EV, or more accurately, 60 milligram eograms. And its advantages are huge. It doesn't cause hypotension, it doesn't have a million interactions with liver enzymes, and you can infuse the whole dose over 15 minutes. In many centers, this has replaced phenytoin as the second-line agent of choice.
And Valproate.
Valproate, 20-40 milligrams is the other option, but you mentioned its caveats. Avoid it in known liver disease or in women of childbearing age due to teratogenicity, if possible.
Okay, let's paint the grim picture. We gave the Lorazepam. We loaded with 2 grams of Keppra or a full dose of phenytoin. It is now 45, maybe 60 minutes later. The patient is still twitching. They are in refractory status epilepticus, stage 3.
Now you call the anesthesiologist. Or, more likely, you are the anesthesiologist who has been called. This is stage 3, general anesthesia. The first 2 lines of defense have failed. You need to take over.
And the first step is?
The first step is to intubate, secure the airway, and start mechanical ventilation. You are admitting this patient to the ICU. The goal now is to induce a coma to suppress the brain's electrical activity completely. Often we aim for burst suppression on the EEG.
What are our weapons of choice here? What anesthetics do we use?
Midazolam infusion is a common choice. Give a loading dose, then start a continuous infusion. Or Propofol infusion. Propofol is very effective because it acts on GABA receptors and also have other mechanisms. You give a bolus of 1 to 2 milligram kilogram, then run the infusion.
But with propofol, there's a specific complication to mention for the exam, right?
You must. You have to mention Propofol infusion syndrome, PRS,
Right.
especially with high doses for more than 48 hours. It can cause severe metabolic acidosis, rhabdomyolysis, and fatal cardiac failure. It's a mitochondrial toxin.
And the nuclear option, if even propofol isn't working.
The nuclear option is a thiopentone, or pentobarbital coma. Thiopentone is the most powerful seizure suppressor we have, but it is a potent, direct myocardial depressant. You will almost certainly need vasopressors, like a noradrenaline infusion, to keep the blood pressure from crashing.
This brings us perfectly to Section 7, the role of the anesthesiologist. It's not just about pushing propofol. We have to manage the airway in a very, very difficult physiological environment. We're doing a rapid sequence intubation.
Yes, you must assume a full stomach. Aspiration is a huge risk.
Now, here is the biggest Viva trap in the world, I think. The choice of muscle relaxant. Succinylcholine versus rocuronium.
Examiners love to pounce on this.
The textbook says succinylcholine is the fastest. But there's a massive risk here.
Think back to the pathophysiology. The patient has been seizing for 40, 60 minutes. Their muscles are breaking down, rhabdomyolysis. Their serum potassium might already be 5.5 or 6.0.
And succinylcholine itself causes a rise in potassium.
Correct. A transient rise of about 0.5 millimoles. If you give Cy-Sex to a patient who is already hyperkalemic from rhabdo, you can push them into a fatal ventricular arrhythmia or cardiac arrest.
So it's a potential time bomb.
It is.
Yeah.
So the safe answer for the exam, the consultant answer, high-dose rocuronium, 1.2 mg/kg. It provides intubating conditions in 60 seconds, almost as fast as Sex, and it is completely safe from a potassium standpoint.
Okay. Safe choice is rhabdo. And once that tube is in and the rocuronium is circulating, the patient stops shaking. They look peaceful. Success.
Danger. The paralysis is not a cure trap. This is maybe the most important point for an anesthesiologist. You have stopped the muscles, you have not stopped the brain.
Right.
If you haven't given enough propofol or midazolam, the patient is still in what we call non-convulsive status epilepticus. Their brain is still being fried by that electrical storm, but they look peaceful because they are paralyzed.
It's a silent catastrophe.
It is. So you must hook up an EE monitor, continuous EEG.
Yeah.
If you paralyze a seizing patient, you are flying blind without an EEG. You treat to achieve electrographic silence or burst suppression, not just clinical silence.
That is such a critical point. I can just hear the examiner asking, the patient is still, are they cured? And the answer is, I don't know until I see the EEG.
Precisely.
Okay, moving to Section 8. Investigations. We mentioned glucose right at the start. What else is mandatory on that blood form?
You are looking for two things: the cause of the seizure and the consequences of it.
Okay.
So for causes, labs, a full panel of electrolytes. Sodium abnormalities, hyponatremia or hypernatremia are a huge cause. Calcium, magnesium,
And for consequence.
renal function.
Yep.
Urea and creatinine to check for that kidney damage from myoglobin, and a CK level to quantify the rhabdo, ABG. You will definitely see a metabolic acidosis with a high lactate, and likely a respiratory acidosis too. And of course, drug levels. If they are a known epileptic on phenytoin, check the level. Noncompliance is the #1 cause of status in known epileptics.
What about imaging?
Once the patient is stabilized and intubated, a CT head is essential. You have to rule out an acute intracranial event, a bleed, a tumor, a large stroke.
Right. Section 9, complications. We've touched on most of these, but to summarize them for a list in the answer.
Just think head to toe. It's a good way to structure it.
Okay, head.
Brain, cerebral edema, permanent neuronal death, cognitive deficits. Lungs, aspiration pneumonia is very common. Neurogenic pulmonary edema can also occur.
Kidneys.
Acute tubular necrosis, ATN, from the myoglobinuria. We might need dialysis. Metabolic, the severe acidosis, the hyperkalemia we talked about.
And musculoskeletal.
A posterior shoulder dislocation is a classic, almost pathognomonic sign of a violent tonic-clonic seizure. Also, vertebral compression fractures from the force of the muscle contractions.
It really affects every single system. Okay, let's shift gears completely. We've managed the emergency. Now let's go to the elective scenario from the intro. Section 10. Perioperative seizure considerations. The patient is a known epileptic on carbamazepine, coming for a hernia repair. Rule number 1.
Never, ever stop the anticonvulsant meds.
So the NPO after midnight rule doesn't apply.
It does not. The risk of a breakthrough seizure from stopping the meds is far greater than the risk of aspiration from a sip of water. They should take their usual morning dose with a small sip of water at 6 a.m. on the day of surgery. You have to write that explicitly.
What about drug interactions? You mentioned these patients have livers that are running on overdrive.
Exactly. Many of the older AEDs, like phenytoin, carbamazepine, and phenobarbital, are potent enzyme inducers of the cytochrome P450 system. They basically rev up the liver's drug metabolizing machinery.
So they chew up our anesthetic drugs faster.
They do. So your non-depolarizing neuromuscular blockers, like rocuronium or vecuronium, will have a shorter duration of action. You'll need to redose more frequently or use an infusion. Your opioids, like fentanyl, will be metabolized faster. The patient might be in more pain than you expect post-op. You need to anticipate this.
And on the flip side, are there drugs we give that are known to trigger seizures, epileptogenic drugs?
Yes, and you should list a few. The classic one for exams is pethidine or meperidine. We rarely use it now, but its metabolite, normeperidine, is a potent proconvulsant. You must avoid it in epileptics and in renal failure.
Okay, no pethidine. What about our volatile gases?
Enflurane, an old gas, was famously epileptogenic. It's historical now, but good for a mark. Sevoflurane is more relevant. It's generally very safe, but in high concentrations, especially when combined with hypocapnia from hyperventilation, it can cause epileptiform spikes on the EEG, particularly in children. It's usually clinically insignificant, but worth mentioning.
Section 11, Viva traps. We've hit a few already. Let's recap them. Number 1 was the paralysis versus cure trap.
Yes, paralysis is not a cure. You need an EEG.
Number 2 was the hyperkalemia and acetylcholine trap.
A very dangerous one. Choose rocuronium.
What about the eclampsia trap? Examiners love to cross-pollinate specialty.
Oh, they love this. A pregnant woman at 74 weeks comes in seizing. What is the drug of choice? If you say Lorazepam, you fail.
Because it's eclampsia.
It's eclampsia until proven otherwise, and eclamptic seizures are treated with magnesium sulfate. A 4-gram loading dose, then a 1 to 2 gram per hour infusion. The pathophysiology is different. It's about cerebral vasospasm and endothelial dysfunction. Don't treat eclampsia like epilepsy.
And another trap, the speed of phenytoin. The surgeon is yelling, "Doctor, the patient's crashing. Just push the phenytoin."
And you have to stand your ground. You calmly state, I will give a benzodiazepine immediately, but the phenytoin must be infused slowly at a maximum of 50 milligram per minute to avoid hypotension and cardiac arrest.
Strong. That shows confidence and, more importantly, safety. Okay, section 12, presentation. If I'm drawing on my answer sheet to break up the wall of text, make it easier for the examiner to grade, what do I draw?
3 things. First, the timeline flowchart. Just draw a horizontal line representing time. At T0 5 minutes, write ABCs, O2, IVXS. At T5:10, write Lorazepam. At T10:30, write Phenytoin Levetiracetam. At T40, write Intubate Propofol ICU. It visualizes the protocol.
Simple and effective. What's number 2?
The drug table. Simple columns. Drug, dose, mechanism, and main side effect. So you'd have phenytoin, -20 milligram Tenana, plus channel blockade, arrhythmia, hypotension. Levetiracetam, -60 milligram SV2A protein modulation, minimal side effects, and shows you know the detail.
I like that. And number 3?
For the pathophysiology section, a vicious cycle diagram. A circle with arrows. Seizure, increased muscle activity, lactate and CO2 production, cerebral vasodilation, increased ICP, lower cerebral perfusion pressure, more brain injury bucket, which feeds back to the seizure. It shows you understand the systemic consequences.
That cycle diagram is excellent. Okay, we are the finish line. We're on the last page of the answer book, section 13, summary and conclusion. We need to wrap this up with a bow. What are the key bullet points for a final summary?
Rapid fire.
Epilepsy is the disease, the predisposition. Seizure is the event, the symptom. 2, status definition. The operational definition is key. A seizure over 5 minutes is status epilepticus and is the trigger for treatment.
It's a tale of 2 neurotransmitters. GABA failure, glutamate excess, leading to excitotoxicity via calcium influx. And remember receptor trafficking. 4, the protocol. It's a stepwise ladder. First rung, benzodiazepine, Lorazepam. Second rung, an AED, Levetiracetam or phenytoin. Third rung, general anesthesia, Propofol or Midazolam. 5, anesthesia roll. Our job is airway, breathing, circulation, but crucially, if we paralyze the patient, EEG monitoring is mandatory to treat non-convulsive status. 6, safety first. Don't stop AEDs perioperatively. Avoid succinylcholine in prolonged status, infuse phenytoin slowly, and treat eclampsia with magnesium.
That's a solid recap. And the final sentence, the mic drop to leave the examiner with.
Something confident and comprehensive. In conclusion, the successful management of status epilepticus requires a rapid, protocol-driven, and time-sensitive approach. The anesthesiologist's role extends beyond immediate airway control to the deliberate termination of ongoing excitotoxic neuronal injury using a tiered pharmacological strategy, always remembering that in this condition, time is brain.
That is perfect. It summarizes everything. So, to the postgraduate listening to this, close your eyes. Visualize that flowchart. Benzo, AED, tube, and propofol. Remember the 5-minute rule. Remember those GABA receptors hiding inside the cell.
And remember, in the exam hall and in real life, always prioritize safety. ABCs first. Don't get fancy with obscure drugs until you've done the basics perfectly.
Good luck with the Gujarat University exams. You have the knowledge. Now you just have to give it the structure. Go crush that Viva.
Good luck. Be safe.